All right, let's start then. So, based as Dr. D'Amico and Josh said, this week is kind of the head and neck cranial nerves week. So the goals of this week are, as Madison said, is sort of just get a broad overview of the head and neck, and nothing like too specific. But we'll have some pearls here and there. But mainly it's to understand the anatomy and relationships of the structures you find there. And you'll be able to correlate the findings of kind of an HEENT exam with the functions of the cranial nerves once you finish Madison's portion, and then just overall integrate kind of your clinical exam findings, your surface anatomical findings, and imaging into sort of a kind of framework for how you'd approach a patient with any HEENT issues. So with that, I guess we can begin just with kind of the surface of the head and neck. How far do we go? And there's really a couple landmarks. Obviously, all the head and whatever is surrounding the cranium. Obviously, what's in the cranium, in the brain, what's in the cervical spine, the spinal cord. We'll cover that in a later week. But in terms of the surface landmarks, sometimes they say it's kind of neck begins where kind of your clavicles, collarbones end. So somewhere up there, but it really depends. But overall, we're going to be focusing on kind of the head, kind of more of your kind of thyroid and larynx area. And then I have a couple of landmarks highlighted here for you guys too. And we'll talk about these a little later, them being the external jugular vein, which you kind of see below the mandible, the thyroid cartilage, which we'll talk about later. And then just kind of, there's like a jugular sternal notch that's often a useful landmark in terms of finding where kind of your sternum starts superiorly. So to begin, let's start from the bottom up with kind of more of the neck. So with the neck, you can see, on the inside, it's kind of divided into several kind of functional compartments. And your pharynx is further subdivided into nasopharynx, oropharynx, and laryngopharynx, each with their own kind of functions, and which then goes on to become the larynx, and then the trachea, or splits into the esophagus. And so this split kind of happens around the area of C3, C4 at the spinal cord, which we'll touch upon just later. But then if you see on the right here, there's the thyroid cartilage, which you might envision, which you might know as kind of your Adam's apple. And then underneath it, there's your cricoid cartilage. And so, you can feel your thyroid cartilage, your Adam's apple, and then you can feel a kind of ring underneath it, your thyroid cartilage. And these are two landmarks that I want you guys all to be able to kind of find, so they can understand later on in the next slide why they're important. And then also in this little structure, you can see the epiglottis right here, which is very important in making sure no food goes down your trachea. And you can also kind of see some of the muscles, on the posterior side of the trachea right here. And then the trachea is covered by kind of rings of cartilage that provide support and stability. And once you get into these rings of cartilage, you're in the inferior, kind of more inferior compared to the thyroid cartilage or the cricoid cartilage. And then your vocal cords, of course, are below your epiglottis. And we'll talk about that in just a moment. So, locating the thyroid, you'll, I think if you have any problems, let us know. But in general, you have your laryngeal prominence, which is kind of just notch in your thyroid cartilage. Your hyoid bone is also superior to your thyroid cartilage. And this bone is kind of unique because it's not really attached to any other bone. Your hyoid bone is kind of suspended, kind of almost in the air, but not really in the air, to the thyroid here by this thyrohyoid ligament, and to your other bones in the head and neck superiorly. And your hyoid bone is really important for being able to vocalize and being able to talk. And fun fact, the hyoid bone right here is one of the reasons why some big cats like lions can roar, whereas like small cats can only like meow and they can't roar because of the differences in the hyoid bone anatomy. So, and I saw it before, like I'll talk about the significance of the cricothyroid ligament. So your thyroid cartilage, as we said, is right here, and then your cricothyroid cartilage is kind of right here. So in between your cricoid and your cricothyroid and your thyroid is this ligament or membrane, the which we call the cricothyroid ligament. And this membrane provides an easy access to whatever's behind, without injuring too many surrounding structures. And I'm not able to see the chat right now, but some of you might know that in an emergency, if there's something blocking the airway, you can kind of make an incision along the cricothyroid ligament, and then in order to be able to access the trachea, like right here. And the reason that we do this is because you see the thyroid is there inferiorly. So by going here, that we can usually avoid injuring your thyroid gland, although sometimes there may be like a pyramidal lobe, but this is not in every patient. So for the most part, making an incision here avoids the thyroid, avoids harming the thyroid cartilage, which is right here, and a lot of other structures. And so I talked about earlier that the C3, C4 level is kind of important. That's where you'll kind of find the superior edge of the thyroid cartilage. That's where you find the bifurcation of your external carotid artery and internal carotid artery. And that's also where your pharynx sort of divides into your larynx and then trachea, or and then the esophagus right here. So another way to kind of show this is kind of this subdivision. And then of course you have your epiglottis that's blocking access to the trachea in the event that you swallow. And the other important landmark to kind of realize is the C5, C6 level. This is the kind of level where you see your cricothyroid cartilage begins, cricoid cartilage begins, and then it's and that, yep. So a slide that I added in here that wasn't, in the slide from last night, but I thought would be helpful for you guys is kind of getting a better understanding of the layers of the face. So, as we said, your face is kind of your HEENT section this week is going to cover, what's surrounding the cranium. So if you start from, on the left image right here, if you kind of start on the left side, you'll see that there's the periosteum, the tissue surrounding the bone, along with the deep fascia right here. So that's going to be, the deepest layer. Above that, you have, depending on where you are in the face, you can have, some ligaments, some spaces right here. And then there's a kind of important muscle and fascia layer right here. It's called the superficial musculo-aponeurotic system. And this layer, and if you remember from previous weeks, an aponeurosis is the end of a muscle. Like some muscles end in tendons if they attach to a bone. Other muscles, like the muscles used to frown and smile, don't really attach to any one specific point in the bone. And a lot of them end in what are called aponeuroses, which are kind of more flat sheets. Oh, my bad. Restart that. So, and then above that, you have more of your subcutaneous fat and skin. So that was a very general layer, description of the layers of the face. And for a kind of more, specific description on the right, we have, a more specific visualization at several points on the face. You see on the neck, you have skin, you have the subcutaneous fat, and then your platysma muscle, which is a very thin muscle in the very superficial portion of your neck. This is the muscle that, when you age, kind of becomes loose and you get neck bands, and that's Some people get a facelift to kind of stretch that muscle back tight. And then below the platysmal muscle, you have a layer of fascia and then some nerves. And this is a common theme you'll notice throughout the face, that the kind of nerves sit right below this muscular fascia aponeurosis layer and another layer of fascia. And then on, at the temporal side, it's pretty similar. You have a deep, temporalis muscle with deep temporal fascia above it. You have your facial nerves above that. But then your really superficial frontalis muscle, which is the one that lets you frown and smile, is pretty superficial to that. And I guess one clinical example of this would be, for example, as I mentioned earlier, for a facelift, you really don't want to get really that deep into it or possibly injure the nerves. And usually, the incisions are done at the kind of the SMAS layer right here. So kind of to get a kind of overview of HEENT vasculature. So, obviously all the blood supply in the body comes from the heart right here. Let me draw a very bad heart, which then goes on to the aorta. And then, depending on which side it is. So on the left side, you directly have your subclavian artery, you directly have your carotid, and then, but then on the right side, you first have what's called your brachiocephalic trunk. And then this brachiocephalic trunk on this side later then subdivides into your carotid and then your subclavian. And embryologically, the reason that this happens is because on your left side, there's actually a trunk too, and that develops, but then it gets kind of sucked into the aorta, so you don't see it when you get born. And so we talked about the carotid. So up until this point, this artery is called the common carotid. And then at about the C3, C4 level we talked about earlier, it divides into the external carotid and the internal carotid. And so the internal carotid supplies a lot of your brain, a lot of the stuff that's inside your cranium, which we're going to really talk about this week. And then your external carotid is what we're going to focus more on this week. And this is the one that really supplies most of the blood to your face. And that one we'll talk about right now. So your external carotid, here you can kind of see a better view of the patient's right side. You see the brachiocephalic trunk right here. And then you see the brachiocephalic trunk kind of divide into the common carotid, and then the internal and external branches of the carotid artery. So your external carotid artery is the one right here. You see it has some branches which we're not really going to talk about that kind of supply most of the face. And that's really what I want you guys to get out of this today, that the face is mainly supplied by the external carotid, that the internal carotid is going to go right here and supply the brain, and is going to pass through the jugular foramen and other things to enter there. So, and something interesting that I do want to share, which is just a tidbit, and it's not, I don't really expect you to remember this, is that there's some of these blood vessels right here. You see these blood vessels on top of the eye, the supraorbital arteries. These arteries actually originate from the internal carotid artery. So like these arteries went inside the brain and then went out and like sort of supplied this area around the eye, which is interesting. And theoretically, because they go in and out, if you have some sort of infection, it can potentially go back in and enter the brain. Yeah. And there's another way you can enter the brain from the face. And if you've heard of the danger triangle of the face, it's right here. So, around the top of your nose and around your maxilla. And this area of your face, the venous drainage from this actually connects with the venous drainage from your brain. So an infected like pimple or abscess in this area, in very severe cases, could potentially go back and cause infection in your brain. So that's why like this area is kind of important clinically. And so this is another overview of the arterial supply of the head and neck. Oh, and then I should have clarified earlier that, this is kind of more, this is just the arterial supply, not the venous supply. The venous supply I'm not really going to talk about today. A lot of the times it's very similar, but then we'll talk about the jugular in just a little bit. So there's nothing really you have to memorize about the slide. Just know that things come out of the aorta, go into the common carotid, and then the common carotid branches off into the external and internal. And a lot of this talks about arteries that end up going inside the brain. So, for example, you have your posterior cerebral artery here, you have your middle cerebral artery here, anterior cerebral artery here, which are all very important in maintaining a blood supply. And the interesting thing is they, as you see here, they all kind of anastomose with each other in the kind of this circle. And the circle kind of helps maintain redundant blood flow to the brain in case there's one artery that ends up getting blocked for some reason. But we'll talk about this later once we talk about the brain in a later week. Right. So as an overview of what I just talked about, here you can see a kind of CT scan. As you remember from the first week, this is a sagittal CT scan. And this is not a mid-sagittal because you can see the middle of the eyeball. So it's kind of offset to one of the sides. And it's CT because the bone's very white here. And, so here you can kind of see where the common carotid at the bottom bifurcates into the internal and external carotid here. And on the right side, you can, this is, as always, a transverse or axial view of the neck. Here you can see the jugular vein, which we said we'll talk about, and then the common carotids. So because this is the common carotid, you see the common carotid, you know that you're below, the kind of C3, C4 level of the neck. And the other way you can know is that, you see just the trachea here. You don't see the pharynx. You already see them dividing. So you're below at that level because that's where they divide. And, as a general pointer, when you see artery and a vein together, the vein is usually larger than the artery because the vein has a thinner wall and can dilate more in case there's an increased pressure. Because when you do an ultrasound and kind of look at the neck and you look at the jugular vein and the artery, the vein can actually blow up to a very large diameter if you hold your breath and kind of bear down. And, if you've ever seen an ultrasound, it's actually kind of pretty fascinating. But, this is all I wanted to get across, the fact that a lot of the face is supplied by the external carotid, things like that. And at this point, I'll pass it off to Madison, who will talk about the cranial nerves. And this is a lot, so yeah, listen carefully. And it's all up to you, Madison. Do you want me to continue screen sharing?
Yeah, you can just continue moving forward with the slides. And if you can, just use your pointer because there's some very involved slides when I'm talking about things, just to point it out, that'd be useful.
Okay, that's good.
Okay. So you can move forward.
All right.
So we're going to talk about the cranial nerves. Just very briefly, there's 12 of them, and they each kind of supply innervation to different parts of the head and neck, which is why it's included in this lecture. Essentially, the difference between cranial nerves and your other nerves, and this is why they have their own name and are called cranial nerves, is that they arise directly from the brain or the brainstem, as opposed to the majority of your other nerves, which arise from your spinal cord. And they will talk more about your other nerves and more innervation and kind of the difference between motor and sensory in the following weeks. But this is more of a broad overview of what these 12 cranial nerves are because they're very important. And the other special thing about some of these nerves is that they include a lot of the special senses. So your things such as sight, smell, hearing, these are all included in the cranial nerves, and it's why they're so important. You can move forward, Ben. So like I said, there's 12. They all have kind of fancy names, and sometimes you'll see them named differently, or sometimes people will just refer to them as their numbers, such as cranial nerve 1 or cranial nerve 2, etc. One good way to remember it is a mnemonic. It's if you're in medical school or you've learned this before, there's a little bit more of an inappropriate mnemonic that people use sometimes, but the way that we learned it in medical school is this more simple mnemonic that's oh, 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 to touch and feel very good velvet, ah, heaven. So essentially that's just taking the first letter of each name of the cranial nerve and putting them in the order since they're all numbered. And the number of these cranial nerves never change, so this mnemonic holds true. Like cranial one, like cranial nerve 1 will always be the olfactory nerve, so they never move around. And something that I included on the side is an alternative for Harry Potter fans. It's just the same type of thing, but it may be more useful to remember if you are familiar with this series. You can move on, Ben. Okay, so this is an overview. I'm going to stay on this slide for a little bit because this is an overview of all 12 of the cranial nerves, just so we can talk briefly about each of their functions. So the first few are pretty simple. The first one is the olfactory nerve, which is responsible for all your sense of smell. It comes from the brain and goes directly into your nasal cavity. And it relays information that, so we're not going to go into the anatomy of the nose or anything because this would be very complicated if we did that. But the nerves in your nose pick up this scent, and then that relays the information back to your brain via this nerve, via cranial nerve 1. Cranial nerves 2 is your vision. So it's kind of the same thing. The nerves in your eye pick up your sense of sight, and then that's relayed back to your brain where it can then interpret the information of what you're seeing. Cranial nerves 3 and 4 have to do with the movement of your eyeball. And so it's actually cranial nerves 3, 4, and 6. Your eye has a couple different muscles, as you'll see in the diagram, if you can see. And each one different directions. So as a result, each one is also innervated by a different cranial nerve. And the interesting thing about this is you can lose, like one of these nerves can become damaged, and then you may not be able to move your eye in one particular direction. So it's a very specific thing that can be picked up on physical exam. Like if you cannot look up, that may be damage to one of the nerves as opposed to all 3. Cranial nerve number 5 is the trigeminal nerve, and we'll talk about this a little bit later. This is a very big nerve, but essentially it provides sensory innervation to the cutaneous parts of your face. So anything that you can feel on your face, like forehead, cheeks, jaw, like when you touch your face, that's your trigeminal nerve relaying back that information to your brain. And it also provides like pain and like temperature sensory from your face, teeth, sinuses. So if you get a really bad tooth infection and it hurts very badly, it's likely your trigeminal nerve providing that information backwards. And it also, the other thing about the trigeminal nerve is that one branch of it provides motor innervation to the muscles around your jaw, so your muscles of mastication, which is essentially just chewing. So if your trigeminal nerve is damaged, you may lose the ability to chew, which is obviously a very important function. Okay, cranial nerve 6 is your, oh yeah, that's the other eyeball nerve that we were talking about, so we'll skip that now. So cranial nerve 7 is your facial nerve. This is also a really big nerve. It lies very closely to the trigeminal nerve, so both can become damaged with trauma to that area. But essentially the facial nerve provides, yeah, as you'll see circled by Ben, it provides motor innervation to some of your tongue, some of your mandibular, and also to your tear ducts. And it also provides sensory to part of your tongue and your soft palate. The sensory for your tongue in terms of taste is split between the facial nerve and one other nerve that I believe Ben just circled, I can't see. But it's split into 2, but the facial nerve provides half of that. So cranial nerve 8 is I just call it kind of like the nerve that you use to hear. So it controls essentially like when you hear something, this nerve will sense that, relay the information back to your brain, and then you can interpret what you're hearing. So similar to the smell, taste, vision nerves as well. But in addition to that, it's also responsible for your balance and motion. So I'm sure you've heard that inner ear problems can kind of cause you to lose balance or get vertigo so that you feel like your head is spinning. So that's also a portion of this nerve that's very complicated in terms of like physics wise, in terms of inner ear. So we're not going to talk about that, but just know that that's part of cranial nerve 8. So cranial nerve 9 is responsible for movement of your tongue. So when you stick out your tongue, move it left, right, etc., a lot of that is part of this nerve, along with, or no, sorry, a lot of that is part of the hypoglossal nerve. So that's cranial nerve 12. So that's the muscles of your tongue, whereas cranial nerve 9 is more responsible for some sensory within your oral cavity. So it does some taste. So it does the posterior third of your tongue that's not provided by the facial nerve. But then it also provides like the sensory of, the top of your mouth or further back in your oral cavity that's provided by this nerve. So between that and the hypoglossal nerve, you get a lot of the functions of your tongue in terms of movement and taste. Vagus nerve is cranial nerve 10. This is a very big nerve in terms of function because a lot of it actually extends past the head and neck, so we will not be talking about that today. But I'm sure, as you've heard, the vagus nerve provides sensory and motor innervation to a lot of your visceral organs in your chest cavity and in your abdomen. So the fact that this is a cranial nerve is interesting. It makes it a little bit unique because it provides functions such as that comes directly from your brain or your brainstem. So we're not going to be talking about that today, but you should know that the vagus nerve is a cranial nerve and is classified as one. And the last one is cranial nerve 11, and this is also a little interesting. It just provides motor innervation to the muscles of your neck and shoulders. So any movement of turning your head or like shrugging your shoulders is provided by this cranial nerve. And also, sorry, could you, yeah. Also, as you can just see in the middle of the diagram, this kind of shows you where each nerve exits the brain or the brainstem. There are really, really good diagrams online. I recommend looking them up so you can kind of get a feel of where each one exits. You don't have to memorize it or anything, but it's good to know, like, if trauma happens to one portion of the brain, or say that there's a tumor in one portion of the brain, possibly which cranial nerves it could be touching or impacting, because then that will affect obviously the function. And now you can move forward then. Okay, and the other thing I just wanted to talk about, which they may talk about more next week, is that as we just discussed, a lot of the nerves carry both motor and sensory fibers. So not only do they innervate muscles in parts of your head and neck, but they may also provide some of those special senses. And each of these are classified differently based on both the direction that they run and what is being innervated. So the difference between afferent and efferent nerves, does anyone know what that difference is? You can just throw it in the chat if you do. Yeah. Yeah, so afferent with an A is information going to your brain. So any pain or special senses, that's going to be afferent because that's information going to your brain. Whereas efferent is going from, so any muscle movement, like your brain directing one of these muscles to move is efferent, so going away into the muscle. And that's kind of specified here. And in this chart is good because it kind of tells you the general function of each type of fiber, and then also tells you which cranial nerves contain this type of fiber. And the two special things that I wanted to talk about here is that special afferent is kind of classified separately, even though it could be a little bit similar to somatic or visceral afferent. They just classify it as special because it's your special senses. So smell, taste, vision, hearing, and balance. There's nothing like the direction is still the same. Just know that it's your special senses as opposed to being something like pain or temperature. And then the brachial efferent, this isn't, I don't think you need to know this for just an overview level, but it's not different than any other efferent. Like it's still providing motor innervation to muscles. It's just based on how these muscles derived during embryological development that they classify this as different. And this is a few of the muscles in your face area. And that's all that you have to know. It's just some of your facial muscles derived embryologically a little bit different. But in terms of motor innervation, it's still the same type of function. And the fiber similarly, and the fiber is similar, it's just, it's named different. Okay. Ooh, I think that got a little messed up. So essentially, what is here is just telling you it's another mnemonic for how it's a little messed up on here, but you can also look it up. This is a very common thing for how, or like what type of fibers each cranial nerve carries. So whether it's sensory, motor, or both. And so the other mnemonic is some say Mary money, but my brother says big brains matter most. So the B's are both motor, the M's are motor, and S is sensory. So that's just another way to help you remember what type of fibers each cranial nerve is carrying. Okay. So in the latter portion, we're talking about some physical exam techniques, because if cranial nerves are compressed or damaged in any sort of way, it leads to deficits in their expected functions. And a lot of these things are very apparent since they are on your face. And can also lead to deficits in your special senses, such as like losing your vision or hearing, or just losing your sense of taste. These are all things that are very noticeable and can point to damage to one of these nerves. So the nice thing about these physical exam maneuvers, even if you're not going into medicine, they're kind of nice to know, because if you spot these things in other people, it can be a sign that, you know, something isn't right. And also these physical exam maneuvers may help you remember the function of these nerves because it's so related to their anatomy and what they innervate. Okay. So you can, yeah. So we're just going to talk about nerves like one by one. In each slide, we'll have a few of them. So the first thing for cranial nerve 1 is just assessing the ability to smell. If you suddenly lose your sense of smell, obviously that can happen with something like an infection. Like if your nose is very clogged up with mucus, that can happen. But if your nose is completely clear and you lose your ability to smell, that could easily be damage to cranial nerve 1. So when you test that, it's kind of like you have someone with the normal ability to smell, kind of sniffs it, knows what it smells like, and then you ask another person to smell it. If they can smell it, cranial nerve 1 is intact. If they can't smell it, there may be a problem. Cranial nerve 2 is the optic nerve. So this is just your ability to see. This will be a very obvious one. You may not even have to test this, because a patient may come in complaining that they've lost fields of vision. And so if there is damage to the optic nerve, it's pretty obvious because the patient will literally lose their sight. The one way that sometimes doctors test subtle changes, though, is to have the patient keep looking forward, and then you move an object kind of like out of their direct line of sight, so maybe like up here, and you ask the patient if they can see it, typically a normal person will be able to see something that's not in their direct line of sight, right? Because we have visual fields that kind of extend more than what we're directly looking at. Even if it's not in focus, you know that an object is there. And so that's a very good indicator of like how well your visual fields are functioning and how intact cranial nerve 2 is. So if a patient can't see something up in the corner that you're holding up that they should normally be able to see, even if they're looking directly forward, there may be damage to cranial nerve 2 or the optic nerve. Cranial nerve 3, the best way to test it is to assess the pupillary response to light. As you may know, if you shine a light in your eye, your pupil constricts. That's just your typical parasympathetic response to light, is your pupil to constrict in bright light. The interesting thing about this though is if you're shining a light in your right eye and the pupil constricts, your left pupil should also constrict. So it's not just one pupil at a time. Typically, even if you're only shining a light in one eye, the other pupil will also constrict in response. So they kind of constrict and dilate together. So if you do this exam and only the pupil that you're shining the light on constricts and the other one doesn't, there may be damage to the nerve on the side where it didn't constrict. So you have to test both eyes to make sure that not only is it constricting to direct light stimulation, but that it also constricts when you're shining light in the other eye. That's a very important thing to know. And I'm sure you may have heard a lot of times in trauma cases, people will say, you know, their pupils are fixed and dilated. That can also be due to the damage to cranial nerve 3 from like extensive head or brain trauma. So this is just a really good way to test that. So cranial nerves 3, 4, and 6. So in addition to the pupillary response, cranial nerve 3 also innervates some of the muscles in your eye, but as we discussed, so do 4 and 6. And so the best way to test these is just to kind of have the eyes in each direction. And this is what this diagram on the right is showing. It's showing you which direction each nerve innervates in terms of the muscle movement. So the best way to test this is to just move your finger or an object in front of the patient and ask them to follow it. If one eye doesn't follow your finger when you're moving it in front of them in a certain direction, it's damage to that specific cranial nerve. So that's a pretty easy one to test as well. Okay, so this slide is all about the trigeminal nerve. As we discussed previously, the trigeminal nerve innervates kind of all of the feeling in your face. There's 3 branches of it. So you'll see in the diagram, there's a main root that's kind of like right next to your ear. And from there, then it branches out in 3 different sections. So one of the sections is kind of your forehead above your eye and your eyelid area. The middle section is like your nose and cheek region. And then the 3rd branch is down your jaw and around your mouth. And the best way to test damage to the trigeminal nerve is to test by just touching the patient in each area on both sides of the face, asking if they can feel it. If they can't feel it in a certain area, that would be damage to the trigeminal nerve. And it doesn't have to be damage to just like the whole nerve. It could just be damage to one of the branches. So if they can't feel in only like their forehead area, that could just be damage to the 1st branch, and the other 2 branches are still intact. Contrastingly, if they can't feel any of it, if they can't feel in all regions of their face, then you know that it has to be the root that's damaged, because that means that none of the branches are receiving or inputting any sensory information. So you know that it has to be the main part of the trigeminal nerves that's damaged and not just each branch. And then the other part of testing the trigeminal nerve function is to ask the patient to clench their jaw down tightly, and you kind of feel to make sure the muscles are intact when they do that and are clenching. And that just assesses the motor function and makes sure that the innervation to the muscle in that area is still intact. I also saw someone mentioned in the chat they asked what trigeminal neuralgia is, and I was gonna mention this as well. Trigeminal neuralgia is essentially like a disorder that causes debilitating facial pain. With any movement of your face, it causes like stabbing pain. So like even smiling for some people is very painful, chewing, speaking, because it's some sort of damage or neuropathy to the trigeminal nerve that makes just simple movements or touching of the face very, very painful. It's rare. It typically happens in women over 50. I am not a neurosurgeon, but I know that there's neurosurgical interventions for treating it. But it can be a very debilitating thing, because you'd imagine if even speaking is painful, it's not a pleasant thing to have. Okay, so cranial nerve 7 is the facial nerve. As we discussed, the facial nerve, similar to the trigeminal nerve, has a few different branches, and you'll see them in the diagram to the right. But essentially, as we mentioned, the facial nerve innervates all the muscles of your face. So this is responsible for facial expression. So the best way to test that the facial nerve is intact is to have the patient do different facial expressions, such as smiling, showing their teeth, closing their eyes tightly, and maybe putting your fingers over their eyes when they do this to make sure that the muscles are like have strength. Because some people, you can kind of like passively close your eyes, but if you ask them to, you know, like clench down and like squint when they close their eyes, if you feel that, that means that the muscle's working properly, and therefore the innervation to that area is also still intact. Another way could also be like raising your eyebrows. There's a lot of different ways to test that the facial nerve is intact, since you have so many different facial expressions, but these are some of the more common ones. To test cranial nerve 8, this would just be testing hearing. So the way that we were taught it is to rub your fingers closely together next to one ear. It makes a very faint sound, but most normal people should be able to hear it. And you just ask the patient, can you hear that? They say yes, that means it's intact on that side. And then you do it also simultaneously by rubbing your fingers together next to both ears at the same time. You ask them if it sounds the same on both sides. Because there's also a possibility that, you know, maybe the nerve's intact on one side, but still like a little damaged, and therefore the sound may be more faint on one side than the other. So it's important to do it also simultaneously to compare, because obviously each side of your face has different branches. Okay, so assessing cranial nerve 9, 10, and 12. This would just be assessing the oral cavity and palate and tongue movement. The best way to do this, there's a few different ways, but one way is to ask the patient to stick their tongue out and say ah. When they say ah, the first thing that you want to look at is the back of the mouth at the uvula, because the movement of the uvula should move whenever you speak, and also when you say ah. And by asking them to stick their tongue out, you should get a good visual field of it. But if the uvula deviates to one side, that could also be damage to one of the nerves, making it so that it's not staying directly in line or moving in the right way. So it's important to look back there as well. And then just assessing the symmetry of the tongue movement. So asking the patient to stick the tongue out directly. If the tongue deviates to one side, that could be hypoglossal nerve paralysis, so damage to cranial nerve 12. And it typically, if the tongue deviates to one side, that's the side that the nerve is damaged on, because the muscle is weak. If you think about it, when you stick your tongue directly out, there should be a muscle on each side that's kind of directing it to go out and stick out straight. Whereas if one of the muscles is paralyzed, the tongue will kind of like flop over to that side because there's no muscle allowing it to stick out straight. So as you can see in the diagram on the right, if the tongue deviates to that side, it means that that muscle is not working, and therefore the hypoglossal nerve on that side could be damaged. And then the last thing is cranial nerve 11. We talked about how this controls the motor innervation to your neck and shoulder muscles, your trapezius muscle specifically. So the best way to test this is to place your hands on someone's shoulder and ask them to shrug up against resistance while you're pushing down. If you can feel them shrugging up and pushing against your hands, that means that the innervation to those muscles is intact. Or another way to test it is to place your hand firmly and kind of like resist the patient while they try to turn their neck or head. And if they're able to do it, or you can feel the force of their neck turning against your hand, that means that the innervation to these neck muscles is intact as well. So therefore, cranial nerve 11 is working well. Okay, so we have some clinical cases that I just wanted to run through so that we can kind of test our understanding of these cranial nerves, and then we'll take questions at the end. So the first clinical case is a 62-year-old male is diagnosed with an aneurysm in the posterior communicating artery of the brain after a repeated history of headaches. The aneurysm is compressing cranial nerve 3. What other signs or symptoms will this patient have? So if anyone wants to guess, you can just throw it in the chat. Okay, you can press forward, Ben, because it'll reveal the answer. Yeah, so I saw a few people say this. Yes, one of the things is that they won't be able to move in the direction of the muscle that cranial nerve 3 innervates, but the main thing is there won't be a pupillary reaction because cranial nerve 3 is responsible for the pupil dilation and constriction. So when you do that light exam, whatever area of cranial nerve 3 is damaged, the pupil won't constrict properly. And this is actually, it's not a common thing, but if you have an aneurysm in the posterior communicating artery, it's very common for it to compress cranial nerve 3 because due to brain anatomy, they run closely together. So even that's another way to diagnose the aneurysm is if you don't have a pupillary reaction, for example, and you have a patient with like repeat headaches and you know it's not due to another cause, like something that you could think is, oh, maybe an aneurysm or a defect posterior communicating artery, given the anatomy, given that they run so close together. So that's just, you don't have to know that. That's just like another like clinical tidbit for you guys. But for the most part, everyone seemed to get it. So clinical case 2, a patient has surgical excision of a parotid gland tumor. After the procedure, he is unable to smile or raise his eyebrows on one side. Which nerve is damaged? Yeah, I see a lot of people saying facial nerve. Yeah. So the facial nerve, as we discussed, is responsible for your facial expression. I saw a lot of people saying trigeminal, which is why I included this, because the trigeminal and the facial nerve are both in the area of the parotid gland. So both are at risk of being damaged if something happens in this area or there's surgery to the parotid gland. But in this case, you know it was damage to the facial nerve because of the clinical signs and symptoms of them not being able to do facial expressions. You know it had to be the facial nerve that was damaged. If they were showing other signs of damage to the trigeminal nerve, such as not being able to feel in certain areas of their face, then maybe you'd be able to say that both were damaged. But in this case, the clinical case is just saying facial nerve. All right, clinical case 3. After being hit on the side of the head with a baseball traveling at a high speed, a 10-year-old boy suffers from a temporal bone fracture. In the ED, he states that the entire side of his face is numb. What nerve was damaged? Yeah, we just discussed this. It's the trigeminal nerve. And I kind of showed where the temporal bone is and like where a fracture may be sustained there. And this would be right at the root of the trigeminal nerve, like we discussed. So damage to the temporal bone in that area, which can happen with a temporal fracture. If it hits the root of the trigeminal nerve, you would lose feeling in your face on that entire side. So like we said, it's not one specific branch, but it's the entire root. So that entire side of your face, you will not be able to sense any feeling. Yeah, and that's about it for the cases for today. I saw, Ben, that you specified something about the pupillary constriction and dilation. Can you just specify that? Because I totally missed it. I might have said something wrong. For clinical case 2. I mean, for clinical case 1, sorry.
Oh, sorry. Okay, so now that I'm unmuted, yeah, so it's not really that big of a point, but you know, as we said, cranial nerve 3, let's see, yeah. Cranial nerve 3 mainly only does pupillary constriction. And so if you have something compressing cranial nerve 3, you'll have pupillary dilation.
Yeah.
And it's important to note that, you know, pupillary dilation is not by cranial nerve 3. Pupillary dilation is a sympathetic nerve response that actually comes from, I think, nerves in your chest that travel up through your neck and then eventually go into your eye. So, you know, if you have something in your neck or like chest that compresses that nerve, instead your pupils will be constricted. But those two are very different systems, dilation versus constriction.
Yeah, that's a great point. Thank you for specifying that. Yeah, so it's mainly looking at constriction reaction. Forget anything. If I said anything about dilation, just forget that. If it's more if you shine a light in the eye and it looks dilated and it's not constricting. I mean, it could not even be dilated. It could just be normal size, but the fact that it's not constricting means that that would be damage to cranial nerve 3. So that's more of the difference. Yeah. But otherwise, yeah, I think we're done unless anyone has any questions.
Yeah, I saw a couple of questions. I saw like a question about Bell's palsy, and couple of people mentioned it. So I think Bell's palsy, I actually like had this as a kid in 7th grade, and it's kind of scary, and and a lot of parents like bring their kids to the ER because of it. But you know, it is damage to the facial nerve, and oftentimes it's damage to the entire root of the facial nerve on one side of the face. So everything from the eyebrows to the chin is paralyzed on that one side. But usually this is reversible. People still don't know what causes it in a lot of cases, especially when it's in kids. But one of the hypotheses is that it could be like for example, a viral infection that can just kind of eat away at the nerve for a little bit, but then it usually always comes back. Like mine came back in like a month or so. Yeah. Yeah, and I don't see any other questions. So.
Okay, great.